So again, let me say it again. Good morning, good morning. Welcome to the Well Project and the WRI third meeting and session on aging with HIV since birth, the journey of women lifetime survivors. We have been learning a lot, answering some questions and finding some other questions that need answering. And so we're going to jump right in here. I'm going to introduce this really quickly and I'm going to go through it kind of fast so that we can get to where we need to get to. Jenna, if you could, thank you. So just a little bit about the Well Project, in case you're not familiar, we focus on women and girls living with and vulnerable to HIV. We are a nonprofit, and we do this by our mission is to change the course of the epidemic. And we do this in a few ways, specifically our strategic pillars: education and information, community support, advocacy and leadership, collaborative engagement, and women-focused HIV research. And you'll find on this webinar, even today, that we are multidisciplinary and multi-sectoral. And that is how we reach the most answers, the best answers. Next slide, Jenna. And so a note on gender and language that we always include because it is important to us. We advocate for the importance of not just gender and language, but person first language, and stress that. And so a lot of our focus and efforts on programming are geared towards that. We work with stakeholders to encourage, again, the use of person first language, and we very much discourage the use of stigmatizing language. And we ask that others call in, not necessarily call out, but call in peers when they see stigmatizing language being used. We celebrate the existence of all of our community members, particularly in this time and where we are right now, our sisters of trans and non-binary experience. Next slide, Jenna. And so let's talk a little bit about our presenters. I am Bridgette Picou. In case you're not familiar with me, I'm the stakeholder liaison for the Well Project and a nurse by trade, and HIV advocacy is my work of heart. We have Alora Gale, who is an amazing advocate, patient advocate, and I'll let her talk a little bit about herself when she jumps into her piece here. We have Sahera Fargo of Ann and Robert Lurie Children's Hospital at Northwestern University. We have Leah Rubin, Hopkins University, and Christina Psaros of Massachusetts General. They are a great group of people, and we have an amazing webinar, I think, planned for you. Next slide, Jenna. And so today's session, we are going to run through our presentations first. It'll be kind of conversational style, and then we will jump into Q&A. Just so you know, at the end of the webinar, you will get a pop-up that will offer to promote you to a presenter. If you have questions or you would like to comment or you have thoughts, please select yes on that, because that is how we will be able to have you come on screen and see and hear you. If you have questions throughout the webinar, please put them in the chat or in the Q&A. We will be monitoring that. We'll hold them till the end and hopefully have an opportunity to cover everything. The webinar is being recorded, and the recording will be available afterwards for you to share with your networks. However, we will not include the Q&A or the recording or the chat and the recording, and that is to protect folks' privacy so that you can feel like you can speak freely and say what you need to do, what you need to say. There'll be a short evaluation at the end of the session. Please, 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 please complete that. It helps us make sure that our programming is accomplishing the goals that we've set forward, and it helps us improve so that we can deliver the best programming that we possibly can and make sure that we're covering all the bases. So please complete that. And then here are some of our resources, which will be available in the slides once they are released. And with that, I am very happy to turn it over to our presenters today. And please enjoy the webinar. And I encourage you to engage with us in the chat. So take it away. We'll get your slides up right now.
Thank you. While we're waiting on those, I'll introduce myself. My name is Alora Gale. I am a lifetime survivor of 40 years. I have worn many hats in the HIV world over those years, from peer navigator to case manager to program director of Babes Network here in Seattle. I have been a Part D rep on our Ryan White TGA. I've worked at Camp Heartland in an effort to connect with other lifetime survivors. I was an advocate or poster child for HIV in the late 90s and early 2000s. And I was one of the first two youth cab members for the national cab for the PACTG. I've done HIV education and presentations in hundreds and hundreds of classrooms, starting when I was in middle school and high school. And I say all this to give me, my words, and experiences some context, which segues into our next topic, the context of language. So, after being told who and what we are for many years, most of our lifetimes, we've chosen the terms lifetime survivor and dandelions to represent those of us who contracted HIV between birth and the first few years of life. Most of us contracted HIV from our birth parents, but not all. We range in age from newborns to nearing 50 years old. Within our community, we recognize that there are distinct generations that shape our experiences as well as our medical care needs. For example, those of us born in the pre-PIs era were born into a world very different than those of us born into the world of medications, even in the early 2000s. We are painfully aware that we continue to add to our membership domestically and internationally. We advocate for research on behalf of ourselves, one another, and those of us yet to come. The term lifetime survivors is a nod to the fact that we are long term survivors and yet our own distinct community within that community. Our bones and former meds lists share similarities with fellow long term survivors, but the funerals that we went to were often those of our parents um, and siblings. And the minimum enrollment age for most studies leaves us behind. We often have too many coexisting conditions to enroll in the studies that are aimed at our age bracket or true treatment experienced. Terms like perinatal or vertical can not only put stigma or blame on our birth parents, but also reduces us to our seroconversion. We would much rather come from a strengths-based mindset. So we choose to call ourselves dandelions as well, from that place of strength and in tribute to Mary Bowman's poem of the same name, Dandelions. In that, she wrote that dandelions live in this matrix of life, understanding the price. For those of us who've lived a life of perpetually borrowed time with such a delicate balance of wellness and illness, I don't know a better way to sum it up. So, lifetime survivors exist. We're still here. We exist within a sea of unique and deeply varied contexts. There are some common threads through, and I hope to speak not only to those, but to also bring forth the experiences you don't hear as often. The folks who didn't attend a study site or affiliated clinic because the stigma was too large a risk for their families, or the travel time too great. There are some of us who are represented in every study we can possibly enroll in, and some of us who've experienced far too much trauma from our childhood medical care to ever set foot in a traditional hospital again, or HIV clinic or study site. Many of us struggle with neurocognitive challenges. Purely anecdotally, since I can't find a relevant study, the number of us who have HIV or ADHD diagnoses or symptoms that were not addressed until adulthood is quite high. Um, and then I often, when I talk about this, I sing the like, maybe she's born with it, maybe it's the trauma Maybelline song, right? Because it's like, which comes first? What could be either. And as I think back to my own adolescence, I not only wonder could have been different for my day-to-day life, be it academics or otherwise, if somebody had struggled. I noticed with executive function. Noticed I struggled with executive function. Not alone. Not. It's been one of those days. Not to mention my challenges to stay engaged with care. To stay engaged in care and complex care and transition from pediatric to adult care requires an intense amount of executive function. I think back to friends who passed away when they were struggling with medication overwhelm or the seemingly endless tasks that a refill can require, right? So you call or use the portal, then you find out you need to get labs done. Then you call the pharmacy to see if they've got it. Then you realize you need the copay assist card or you need to call insurance. Maybe you have to go back a second time and hopefully you walk out with meds. But when you think about that layered with the complexity of everything else, it can feel impossible, right? So then you think about the family system within the context of hereditary neurodivergence, and you see the cracks of systems of care and missing data. It just splinters outward. We can't go back, but I do know that we can do better going forward. These nuances shape not only our relationship to HIV, ourselves, our families, our partners, but also how we show up in the data that we do have and the data we do not. Our stories, our disclosure, our healthcare, our outcomes, even the very genotype of our virus is intimately woven into those of our families. Into our adulthood, our choices and decisions around our lives with HIV are not solely our own. We walk a delicate line between our individual needs and autonomy and those of our families. Our mothers, fathers, siblings, grandparents, aunties, and finally our children, who are often the third generation of our family to have taken HIV medications, although prophylactically. And from there, I will pass it on for the next slide.
Thank you, Alora. My name is Christina Psaros. I am a clinical psychologist by training and also behavioral scientist. So it's via those lenses that I'll provide some remarks today. And I think, Alora, you contextualized this slide so eloquently. But when we think about aging as a lifetime survivor, I wanted to provide a little bit of context in which we might think about that process. And it really needs to go beyond successful aging, and the promotion of well-being really needs to go beyond viral suppression. So it's important to think about the developmental context in which aging occurs among lifetime survivors. So we have here an evolving social context. I think we might say that the social context is evolving much too slowly with respect to how HIV and persons who are living with HIV are seen, and still tremendous amounts of stigma and discrimination, though we may see small pockets of progress here and there. Uncertainty. So again, living through very different chapters of what treatment looks like, the availability of treatment, navigating long-term biological effects of treatment. And some of my co-presenters will talk extensively about these factors a little bit later on. Alora touched on this, but there's loss, and there's loss to consequences of the virus itself. There's loss associated with disclosure, whether that was intentional or not, but family, friends, partners, community loss over time, losing community members, other lifetime survivors with whom you formed relationships. And of course, with aging, we have the addition of another potential ism. So many of us, we all carry around different identities, and we see stigma around those different identities, and with aging involves the possibility of age-related stigma and discrimination on top of other stigma or discrimination that we may be navigating. And in many cases, these experiences can contribute, at a minimum to chronic stress. And in many cases, we actually see the cumulative burden of these experiences as trauma. Next slide, please. So just to comment briefly on what we mean by chronic stress and trauma. Stress is conceptualized as this experience of being pressured and our coping resources generally overwhelmed. And when many of us may experience that in kind of chronic capacities. Trauma, as defined by the American Psychological Association, is a lasting emotional and physical and psychological response to distressing events. And for many lifetime survivors, we have to acknowledge that it's not a singular traumatic event, but rather multiple events, traumatic events that have occurred over a prolonged period of time with, again, cumulative effects. So in the context of chronic stress and in some cases trauma, we may see anxiety. So physiological activation of this fight or flight response, a heightened hypervigilance. We see grief, we see guilt associated with loss. We see avoidance. So avoidance is a protective mechanism, right? So staying away from that which might create stress or remind us of trauma. And the flip side of that is that for those of us who, for people who may have had trauma in a healthcare setting, we might see a generalized response to avoiding all healthcare because it has been a traumatic experience. We also see, in some cases, this kind of high impact coping and a vulnerability towards using or abusing substances, which are very effective means by which to alleviate distress, but obviously come with a fair number of negative sequelae. So these are some of the things that we might see in the context, again, of aging in this really unique context. Next slide.
Thank you, Christina. I'm Sahera Fargo. I'm a pediatric infectious disease physician. And I just want to point out the study that highlights rates of myocardial infarctions or heart attacks in people living with HIV, highlighted in blue in this bar graph, and people without HIV highlighted in green. And you'll see these are data that are based from administrative hospital database. And I really like this study because it was one of the first to really highlight that young adults living with HIV have a higher rates of heart attacks even between the ages of 18 and 35 years of age. And as Alora and Christina so pointed, is we have to think about complication, which I think we're all aware of, but we often think about comorbidities in quote unquote older adults, which unfortunately I think I fit in this category now, but 40 and above. But this was really kind of the first study to highlight that there are actually higher rates of comorbidities, and not only just precursors of complications, but actually higher rates of true complication that can lead to morbidity and mortality. What's interesting here, if you'll click on the cursor one more time, is that population between the ages of 18 to 35 years of age has a fourfold higher rate of myocardial infarction when we compare people living with to without HIV. However, this study didn't tease out whether these 18 to 35 years of age were dandelions or lifetime survivors and what the sex occurrences or prevalences were. And this is a recurrent theme in a lot of this literature when we talk about comorbidities and aging. Yes, we have a lot of data, but a lot of that data hasn't been teased out in terms of whether we're talking about dandelions and lifetime survivors, and also whether we're talking about men versus women. So next slide. I think the other thing I really want to highlight, and again, bringing back to what Alora so eloquently introduced us with, this concept of just challenges facing lifetime survivors. Lifetime survivors are facing, and I've been initiated on older regimen and have often initiated ART at period of critical immune development. So when you think about immune ontogeny or immune development, those first few years of life are critical, and those immune cells are seeing sometimes much older and more quote unquote toxic regimen. So when you think about, Laura mentioned PACTG, when you think about those older drugs like DDI, D4T, AZT, they were and are still, even despite the fact that we're no longer prescribing them, continue to remain toxic to the immune system and the quote unquote energy powerhouse of the body, or the mitochondria. So we're really comparing apples to oranges when we think about lifetime survivors, and challenges when we think about the pathology and physiology of the impact of long-term complications. it's also becoming a little bit difficult. And I'm speaking of this as a pediatrician in terms of, fortunately, I showed you data on myocardial infarction, but I'm not seeing, younger patients in my clinic who have myocardial infarction, thankfully. But it becomes harder to figure out really how to measure those long-term heart outcomes in a clinical fashion. The other thing to think about is differences in terms of traditional risk factors, and Christina touched on this in terms of substance use and social determinants of health are really different, not only in different settings when we think about urban versus rural, but when we think about in a global sense, right? Global North versus global South. And then when we do measure those risk factors, how do we put them into context? And when I say risk factors, I really mean kind of precursors of long-term comorbidities. How do we put them into context? How do we use them to really inform lifetime survivors in terms of how to mitigate long-term complications? Next slide.
I think the next one is mine. I don't know. Thank you. So I'm Leah Rubin, and I come to you with a background in cognitive neuroscientists, and I'm also an epidemiologist. So I'm kind of, I've been focused very much on neuro, and as Alora mentioned, a lot of the kind of cognitive complications that folks experience. And so we've heard a bit about many of the biological, some of the medical and psychosocial challenges that have really faced women aging with HIV, particularly lifetime survivors. And I'd like to spend the next few minutes talking about why all of those factors ultimately matter for the brain. To me, the brain is where really biology, physical health, and the lived experience all intersect. And so when people hear the term brain health, they often think only about memory or dementia. But brain health is really a much broader construct than that. So brain health, it doesn't just include our ability to think, to learn, to pay attention, which I don't know because aside from my speakers here, can't see anybody else's faces. So it's that attention, the ability to remember what Alora may have said 4 slides ago. But it also encompasses how we regulate our emotions. I know, Christina, you spoke earlier about stress, and especially when we're young, right? That ability to regulate our emotions isn't necessarily there because our prefrontal cortex isn't fully developed until we're 25 years of age. So we need to think about, we have the memory, the attention, how we regulate our emotions. We can also think about how well we sleep, how well we move through our environment, and how we connect with others. So our interpersonal interactions and how we just function in our everyday lives. And really, it's together that these domains really influence our ability to remain independent and to maintain a quality of life as we age. Next slide. Okay. Now, for women aging with HIV, and especially for lifetime survivors, brain health, and we've kind of heard this with other aspects, but brain health is really shaped by a lifetime of experiences that begin early and they tend to accumulate across the life course. And I think lifetime survivors, they really provide a unique lens in which to understand brain aging because many of these exposures begin early in life and they continue to evolve over decades. So I can't quite use the cursor to kind of point out the timeline or, the kind of life course development here, but some of these influences are biological, right? So including HIV itself. We have lifetime of antiretroviral therapy, chronic immune activation, and even in later life, we need to think about going through puberty, the menopausal transition. So those are other kind of more female specific factors that we need to be thinking about. Others are psychosocial, including, and we heard from Christina, we have stigma, trauma. We heard about social isolation and mental health. And then we've heard from Sahera that the physical health also contributes through factors such as sleep, cardiometabolic health, as well as physical activity. And I think what's most important is that these factors do not occur in isolation. They unfold within that broader structural and social environment that influences access to healthcare, healthy food, safe places to exercise, education, and other resources that really support healthy aging. And I think the key message is that these exposures, again, they don't occur one at a time. They accumulate, they can interact, they can reinforce one another over the life course. And ultimately, it's the cumulative effects of these biological, physical, psychosocial, and structural factors that really shape brain health and how the brain ages. And so I think our goal isn't simply to help women live longer with HIV. It's to preserve brain health so women can maintain their independence, their quality of life, and continue to thrive as they age. Next slide.
Would help if I remembered to unmute myself. So as we're talking about, I feel like I'm learning so much. As we were talking about everything that Christina and Leah and Sahera have brought together, there's the piece of lifetime survivors or dandelions where we just stand a little bit out, right? So we as a community are aware that we're aging at a unique pace. Increasingly, we have data points to actually should back that up. And a major challenge that remains is the burden of applying that to our care, right? So if we are able to find it, data, if we are able to find studies and then bring it to our provider, that burden is still on us, right? Many of us are not in pediatrics anymore. We are the only lifetime survivor at our clinic, or we are seeing a GP because we have so much stigma and so much like internalized stigma or trauma around an HIV setting that we're seeking care elsewhere. Or that's what's available to us just by way of our healthcare system. So while we can extrapolate that data from fellow long-term survivors, it's not straightforward on how it applies to us. More critically, when it will apply to us, right? Again, thinking back to those generations, those kind of distinct generations of us who are dandelions and where we came in along with all of that data. So be it menopause, bone density, or even why there's a sudden drop in our CD4 count, we can't find information, let alone the shingles vaccine, right? For us, there's significant hurdles to access care that is more accessible to other long-term survivors based on age and approval processes. So let's play a little, real life case study kind of game. So let's take shingles as a common one for my community. Say you're in your 20s, you have had an undetectable viral load for years, you have a absolute CD4 count over 300s, you're almost a year postpartum, you're working full time, and you're caring for an aging parent. Super common setup, right? The familiar tingle starts, right? You see a provider, urgent care, can't get into your regular provider that quickly, and you're told you have shingles. This is your 6th round of shingles in 10 years. You take off work, your income suffers. You take extra precautions around your baby since they're too young for vaccination, and you're panicking constantly because you spent your entire life warned, scared, criminalized around the infectious disease that you share in your body, HIV. And that trauma does your immune system and recovery no favors. You can't take care of your aging parent as they're recovering from chemo and can't risk varicella. So you have to pay someone to sub in for you. This is not the first time you've had to call it quickly and your job's not stoked. But you also can't really go in with shingles like on your face. It's tricky. While you've worked there for several years and qualify for FMLA, you can't disclose your HIV status because you know that your boss will freak out. You don't want to risk that, ruining that workplace for yourself. So you could apply under some other reason, caregiving, etc. But you also can't help envying that your dad can just say cancer and it's that easy, right? And do that paperwork without that stigma. So you finally see your ID doctor. You bring up the shingles vaccine because you figure you qualify for it either due to CD4 or the repeated exposures. And they say, yeah, but now insurance won't pay, right? Because you don't meet the age qualifications. So you start the prior authorizations. You take 2 passes and you get a PA, and then you take your screaming baby because they're stressed out, right? They feel you're stressed, and have a semi-public argument with your pharmacist, telling them that you are actually eligible and bringing up documentation despite your age, and you finally get the shot, the first shot. but then you feel so crummy you have to call out of work again, right? And your boss is getting suspicious. So when it comes time for the second shot, you forget it and figure it's not worth rescheduling, right? You've done all of that work, you've got to that point. This is all too common for the reality of accelerated aging with a delicate immune system and in systems that aren't fit for us, right? Somehow we fit in no boxes and every box. And so we just kind of float between them all. Next slide.
So I have the tough job of following that case scenario, to which, as Alora pointed out, is very common. And I think you alluded to this when we talk about lifespan and health span. Although we've made tremendous progress, you can see here in red the expected survival for a 40-year-old woman who started and initiated ART before 2015 compared to women who started ART after 2015 compared to the general population. And then here, similarly, you can see men on ART before 2015, after 2015, and the general population. So we've made tremendous stride in terms of increasing survival. Next slide. But I want to point out that years gained have not been without cost. And I think both Alora and Alison Agu in the first webinar alluded to this. So I want you to focus on the bottom of this graph, or the orange dots and triangles. You can see without HIV, population that live free of comorbidity versus people living with HIV and the burden of comorbidity-free years. So on average, people living with HIV have 15 fewer comorbidity-free years compared to the general population. And again, these data really highlight that, especially as a provider, I have to ensure that I ask the right question, that I do the adequate screening. But again, these data are really not focused on lifetime survivors. And really, most of the data that we have are really on adults, older adults living with HIV, regardless of how long they've been living with HIV for. Next slide. And again, this is really just putting in a graphical form what Alora mentioned in terms of accelerated aging. And this is really scientifically the process that we're aware of and the data that we have. So you see here in blue the aging process in the general population, and it's hypothesized from data mostly from what we call epigenetic aging. So when we look at the biological clock versus the chronological clock, we know that the aging process in people living with HIV is accelerated. And with ART, we think that that's dampened. However, it doesn't really quote unquote normalize, although I hate to use that term. And we believe that aging continues to be, for lack of a better term, continues to be accentuated. And again, I'm going to sound like a broken record, but we have very little data in terms of this aging curve in dandelions and lifetime survivors. We have some data in the pediatric population still suggesting that there appears to be accelerated aging even during teenage years, but that data is still lacking. Next slide. And so I'm going to focus a little bit on cardiovascular morbidities because most of you probably know that's the number one comorbidity that we're dealing with in terms of aging with HIV. And when we think about, I want to focus on younger adults. Again, I'm a pediatrician, and it's hard to really diagnose those hard outcomes because fortunately, we're not seeing them in the younger teenage slash, adolescent and young adults. And so the data really tells us that we're already seeing precursors of cardiovascular disease, even in a generation that has not necessarily been on older regimen or protease inhibitors for decades, but we're already seeing evidence of insulin resistance, dyslipidemia, visceral obesity, which we know that's the type of adiposity tissue that's associated with long-term complication, and then not all fat is created equal. And what I mean by that is that deposition that we're seeing is dysfunctional. It's more inflammatory. It's caused with long-term complication. And again, all of those are not just solely associated with HIV. They're really associated with HIV, despite viral suppression, antiretroviral therapy, health behaviors, and relationship in childhood. And I think we'll touch on that. We know that adverse childhood events are associated with long-term cardiometabolic complications. Next slide. And so when I talk about HIV-related cardiovascular comorbidities in lifetime survivors, we definitely have evidence of cardiomyopathy. There was a great study by the pediatric HIV cohort study that looked at evidence of cardiomyopathy in lifetime survivors. We have evidence of subclinical vascular disease, evidence of endothelial dysfunction, and cardiac fibrosis and inflammation. I've highlighted the modalities by which these are measured, and you can see some of these or most of these are not your typical measures when you go to your GPs, right? So they're great for research studies and definitely give us evidence of precursors of cardiovascular disease, which are known to be associated with heart attacks and strokes in the general population, but not necessarily easy to do in a GP's office. Next slide. And so Alora alluded to this. We often talk about neurocognitive impairment, ADHD, cardiometabolic disease. Often those are the two most common that I will be screening for in our offices. But I think what's lacking is the knowledge that these can co-occur and often co-occur. And there is very little data in terms of what comorbidities and what the phenotypes tend to be. And I think we have some data in the general population highlighting the fact that a lot of time morbidities happen in a certain phenotype. So for example, again, cardiometabolics are more likely to occur with neurocognitive impairment. But in terms of lifetime survivors, these are again data that we're lacking. Next slide. And so what I find interesting is when we think about ways to protect, and I'm going to go back to cardiovascular health because that's the comorbidity and complication that's the most often studied. The majority of prevention studies often happen in adults over the age of 40. However, we know that risk factors that tend to cardiometabolic complications happen before the age of 40 and really are combined in terms of individual risk factors that are listed here, interpersonal, community, and also the impact of cohort effects. So I really want to highlight that we have a vast amount of knowledge for how we can do counseling and provide information, health information, but we have so little data in terms of how to mitigate that for adolescent and young adults. Next slide.
All right, so back to me. So again, Sarah, it's amazing to go right after you because again, the concepts that I'm bringing, it's just we're thinking about the concept of that the brain again doesn't age in isolation, and you're tapping on all of the pieces. So I feel that as we know, the brain is interconnected with the health of the rest of the body. So you've really touched on cardiovascular health. So that's going to influence brain health. You've mentioned the metabolic as well as hormonal changes that all communicate with the brain throughout life. And when any one of those systems is disrupted, it doesn't just affect that organ system, right? We have to think about it's a system, right? It's systems biology. So it's going to have downstream effects on the brain and ultimately brain aging. And again, for women aging with HIV, these interactions become even more important because they're occurring in the setting of chronic HIV infection with persistent immune activation, with long-term ART, and for many women, again, the menopause transition. And I did see a comment in the chat earlier. So I was kind of asked to spin my slides more towards women's health. So it's not that I don't focus on men. It's usually a comparator, but women have primarily been the underrepresented group. And then you can even think of the lifetime survivors within that have even been, and I think we had spoken on our call yesterday just to kind of prepare for this. And within the Women's Interagency HIV study, I got all of my data correct, but it's actually an exclusion criteria. So, that does beg the question that these large epi studies, that lifetime survivors are not within those large databases and the information that's coming out. So Alora, I did my due diligence to kind of figure that out. And that, brings up a whole nother set of questions. But anyway, I just wanted to brief that because I saw that in the chat, and we're not trying to ignore lifetime survivors that are male, but kind of spinning this to women, and also, haven't really thought about menopause and all of these factors that influence brain health. And so that these biological processes, as I mentioned earlier, again, they're in these broader social and structural factors that include healthcare, nutrition, social support. And in other words, brain health isn't simply about the brain, and we need to think about the reflection of overall health across multiple biological systems and in the environment in which we live. And understanding those interactions is really critical if we're going to develop interventions, not only to help women live longer with HIV, but also to preserve brain health. And so that's kind of the theoretical kind of map per se. And if you go to the next slide, the conceptual kind of framework that I presented, it's not just theoretical. Over the past decade, our group has actually, and others, have focused on understanding the factors that shape brain health in women aging with HIV. And again, as I'm primarily through the Women's Interagency HIV study, now the Max Wise Combined Cohort study, which is the largest longitudinal cohort of women living with HIV. But again, they're missing the lifetime survivors. So everything I'm going to say, it's, you have to ask the question of generalizability, right? And that maybe it's compounded with, having been exposed earlier. But what has become increasingly clear, as I mentioned, is that brain health is influenced by these multiple interconnected factors rather than any single biological process. We've done, tons of work, and we've seen, you can start at the top, that menopause, the transition in and of itself is associated with changes in both cognition and mood. We've seen important relationships between sleep, physical health, cardiometabolic health. I mean, we can kind of go down the list: HIV, immunology, mental health, metabolic health. We've studied both antiretrovirals as well as non-antiretroviral medications, thinking about polypharmacy and all of these medical comorbidities. That also means that people are taking many medications. And all of these things we've seen to influence cognition. And we've also seen, there was a mention earlier about substance use, but crack cocaine, heroin, I mean, all of these things we've seen to be associated with poor cognitive health. And within HIV specific factors, we've also kind of dug deeper and have looked at chronic immune activation, endothelial dysfunction, the HIV reservoir, the individual ART agents. And again, they influence cognition, and it's not like a one size fit all. Like, it may not hit every domain, memory with motor function the exact same, but it influences cognition. We've even dug deeper and have gone down the route of putting individuals in the scanner and looking at brain MRIs. And we've seen that there's evidence of neuroinflammation and blood-brain barrier disruption and structural abnormalities that also have provided biological insight into the mechanisms that underlie a lot of the clinical findings. And that individually, I think each of the studies that have been done, they answer important questions, but it's really the collective that tell a much larger story that, again, the brain health really reflects the cumulative effects of all of these things across the life course. And so, I mean, this is what we've done. Others who I'm sure are on the call, I think I saw Shivani Mukherjee. There are others that focus on these things as well, but kind of pulling it all together you're kind of focusing on each of these things in isolation. But when you start pulling it all together, it really gives you the big picture. So if you go to the next slide. Is that mine? Okay. I think one of the most important lessons that we've learned is that there isn't a single brain aging trajectory for women living with HIV. When we follow women over time, we don't see everyone declining at the same rate or even following the same pattern of change. We see some women remain remarkably stable over many years. Others experience a gradual decline, while smaller groups, they decline more rapidly. And I think importantly, these patterns aren't necessarily consistent, again, as I mentioned, across cognitive domains. So a woman, you can kind of see this on the left and the right, who may show declines in memory, may remain absolutely fine in motor function or vice versa, right? And this heterogeneity, all of these individual differences, I think tells us something extremely important, that HIV alone doesn't determine brain health. I think instead women are arriving at old age with very different combinations of biological, behavioral, psychosocial, and structural exposures, and that those cumulative experiences may not only shape brain aging, how it occurs, but how it unfolds over time. And so to me, this shifts the question from simply asking whether HIV affects cognition to asking why some women remain resilient while others become more vulnerable. And I think that's where the field is headed and where we have the greatest opportunity to improve brain health as women age with HIV. So going to the next slide. And so heterogeneity doesn't just stop with how cognition, memory, other mental abilities change over time. You can even look at women at a single point in time, and we don't see a single pattern of how people perform on different cognitive abilities. Instead, women tend to exhibit different, what we would consider different cognitive phenotypes. So again, you can see here on the left, and again, this is within the Women's Interagency HIV study, there's 33% that were cognitively resilient, right? What makes these women cognitively resilient? And then you can see that there's other groups of women show weaknesses in different cognitive abilities. So whether it's processing speed, learning and recognition, or kind of more of a broader multi-domain impairment. And what's particularly interesting is that these groups of individuals are not being explained by the same underlying factors. So we see different combinations, again, of those biological, clinical, and psychosocial characteristics that are associated with these different cognitive profiles. In other words, you can have two women, right, who have very similar, if you were to just look globally, they may look the same overall, but they may have gotten there through very different biological pathways. And to me, it reinforces a really important concept, that there isn't a single mechanism that underlies brain health in women aging with HIV. There are multiple pathways that could lead to different cognitive outcomes. And if the biology is different, then our biomarkers and our prevention strategies and ultimately the interventions are going to need to be very different as well. Next slide. Okay. So I've spent the last few slides talking about the remarkable heterogeneity we see within women aging with HIV. But I think another really important lesson from our work and others is that heterogeneity also extends across the sexes. So as we think about biological sex, and when we apply the same analytic approaches in women and men living with HIV, it's not the same. We see different cognitive profiles in men than in women. The patterns of strength and weaknesses differ. And we've also found that the factors that kind of contribute to each are different as well. And so these findings tell us that women aren't simply underrepresented. And again, I focus very heavily within women with HIV because they were an underrepresented group, especially as we think about brain health. The majority of the work had been focused in men. and that women may experience fundamentally different patterns of brain health. They, as we mentioned, they experience unique biological exposures, including reproductive aging and menopause. And they also experience different social, behavioral, and structural influences across the life course. And that together, they're going to contribute to different differences in brain health. And so understanding these differences isn't simply about representation. It's about really discovering the biology that would otherwise remain hidden if we just kind of combined everybody together. And it really enforces a larger point that, again, brain health is far more than just thinking about HIV itself. Again, it's kind of bridging back to that. It's the cumulative interaction of HIV and HIV-related factors and how that's interacting with mental health, substance use, the environments. And again, if our goal is to preserve brain health as people age with HIV, again, we need to move beyond that one-size-fit-all approach and towards that more precision brain health approaches that are really recognizing different people, that how they arrive at healthy aging through these different pathways. So
Thank you, Leah and Sarah. So I'm going to circle back and talk about some kind of practical considerations. When we think about mitigating cardiometabolic risk and or supporting brain health, a lot of that comes down to what behaviors can we kind of encourage lifetime survivors to engage in, and what are the factors that may influence any individual's success at engaging in those behaviors. So we really can't have that conversation without talking about some structural issues, and kind of the disproportionate burden that persons living with HIV, including our lifetime survivors, have to navigate to access some of these behavioral strategies. So the food environment is a very important factor that we have to consider. So we have both food deserts and food swamps. So deserts referring to kind of a dearth of available foods that may promote health and well-being and are generally considered healthful. And then we had food swamps, so kind of on the opposite end of the spectrum, an overabundance of highly processed fast food, kind of inexpensive options that may confer additional risk. Then there's also the built environment here. And we have to consider things like, how walkable is an individual's neighborhood? Do they have sidewalks? Are there spaces for recreation? Is it safe to be outside engaged in physical activity? Safety in terms of like one's physical integrity, but also air quality if people are engaged in activity outside, traffic safety, et cetera, et cetera. So again, we know that persons who are living with HIV, including long-term survivors, again, are disproportionately affected by some of these structural issues that make it hard to engage in behaviors that could otherwise mitigate risk and promote healthful aging. Next slide. Also a word on just providers and how providers can support dandelions and long-term survivors. So this is a conversation that we have to have in the context of the current healthcare system, right? And the way that a lot of specialty care is siloed and requires a fair amount of rigmarole to access. And I'm just reflecting back, Aurora, on your experience or your kind of anecdote around what it takes to even get a prescription refilled in the context of doing a million other things and potentially navigating shingles. So accessing care is really difficult. Also, I think, we've left a lot of providers feeling like they aren't certain how to manage all of the complex health needs that lifetime survivors may have. And we probably need to come up with better support systems for our providers as well. But then, we also have to keep in mind the other side of the coin, that in the case of, say, primary care, we're asking primary care providers to do more and more and more things with fewer and fewer resources, and that doesn't necessarily feel great either. And I'll just make reference to, there's an initiative called Her and Now that's being run by Sarah Luby and colleagues, which is kind of a neat example of how we might help providers. It's kind of an a collection of tools to help providers learn about menopause among women aging with HIV. So very informed by our target population, asynchronous and synchronous content. So again, we need to kind of get creative about how we help providers. But when we think about care, again, I think there's no doubt that it needs to be comprehensive. And we need expertise kind of beyond infectious disease and HIV care. All the care we provide needs to be trauma informed because we have to know or be able to understand the complex pathways that our patients have had to navigate to get to us, and that may include experiences of trauma. Mental health care, we know that we can see elevated rates of depression and anxiety among persons living with HIV as they age. So mental health care has to be part of the equation, especially when we know things like depression can really compromise an ability to effectively take medication, to engage in physical activity, to leverage social support, to engage in substance use treatment. I mean, it's all embedded. We also need to think about support for helping people navigate these structural issues that compromise care. So housing support, accessing food, physical activity, OT, PT, etc. So again, a really comprehensive, or ideally, if we're going to talk about the ideal setting, it would include all of this multidisciplinary care. Next slide. This is a related but slightly separate point. So housing is also health. In this study here from 2024 found among persons who are living with HIV and also aging, people had an average these 6 structural instability factors, all of which are associated with more adverse outcomes, including greater substance use and poor overall health outcomes. And again, we're talking about housing stability, having enough socioeconomic capital to meet your basic needs, transportation to get to your appointments, the ability to engage in employment and educational opportunities, etc. So again, our population here experience a disproportionate number of these structural challenges that can compromise health. Next slide. This, I believe, back to you, Alora.
Yeah, so I'm still taking in everything. Thank you all. Thank you all for the work you do and what you bring forward. And I really wanted to touch in particular about what Christina was talking about in terms of trauma-informed providers and the structural issues with how we can access care. So lifetime survivors have often experienced medical trauma that limits our access to care. And our stories are complex. And so when we talk about those siloed care, when we talk about all of these aspects, it's hard to imagine bringing it all together in some ways. And I am going to get very vulnerable. I believe that vulnerability is our superpower. And so often we talk about these stories in such an abstract way and don't see the reality behind them. So, outside of social work or outside of HIV work, like many of my peers, I hold seemingly countless other titles, identities, and experiences. I'm a mom and a bonus mom to a pack of 4 teen boys. And I am the wife to a man who is my exact opposite in all the best ways, who was able to naturalize a year ago and had citizenship, even though he's been in this country for his entire adult life. I am the sister of someone who is living with HIV. I am the daughter of a mother who died of complications of HIV in 1995. I was a caregiver to my father after he experienced a major stroke and several rounds of cancer. My childhood friends are a mix of people I met in school and my community who remember that meeting me and my family, we were out about our HIV status since 1992. And 75% of us were HIV positive. They remember meeting us was their introduction to HIV, right? And I lived in often rural areas. There wasn't a lot of visibility. And My other child friends were folks whose families were on the same path as ours, navigating treatment care in a world with so much uncertainty and instability and no answers, but a lot of questions, right? Most of them have died years ago, decades ago, awaiting medication that would actually work, or due to the side effects of the medication that could have saved our lives or sent us into organ failure. And it felt like a flip of the coin was the difference between those. But at the time, if you had organ failure, there were no donors, were not an option, right? So that was the end. When folks talk about reunions, right, I picture my high school class and a pediatric waiting room of empty chairs, right? Those are my reunions. I am plagued by survivor's guilt. I can point out which veins on my body are good for blood draws or for an IV. I have preferences for both. I can experience nostalgia in a really long MRI. I can pour out names of loved ones for a World AIDS Day event when we have memorials. When I was pregnant with my first child, I was 25 and my labor stopped for hours and I had a full-blown panic attack when I transferred to the hospital because the smell to give birth, because the smell of it reminded me of my mom's last days. I often think about how much coaching I received in my life on how to keep everyone safe, right? And in my brain, how that implied that I was intrinsically unsafe. And where I walked in the world was going to be unsafe for others. Like it was a character flaw. Or the number of times I was offered a condom to protect people, but was never told what to do with my used tampons, right? There's blood everywhere. And there was no conversation about that. As a mother to children living with disabilities and having been a case manager in HIV, it has been my literal job to advocate for others in medical settings, and I can do it well. I had a lot of training. I have had to discuss options of care for my children that nobody should ever have to think about, and I was calm, collected, and effective. But when I've talked to my beloved doctor, who I've worked with for 12 years, about a medication change, every time I sob. My ability to advocate is gone. Some piece of my PTSD, CPTSD is activated, and I am no longer an effective advocate for myself. The various pieces of me and my family and my history all disappear. It's just the trauma that holds strong. So when we talk about lifetime survivors, and I walk into these spaces with immense privilege of varying degrees, when we talk about accessing care as lifetime survivors and what that takes, it is so unique to each of us and is so much more complex than any of us are saying in those appointments. So I bring that. Next slide.
Thanks, Alora. So we've mentioned this a couple of times, but there's this issue of, well, what does behavioral science tell us about how we can support lifetime survivors during their aging process? And unfortunately, we don't have a lot of data, I guess, to put it quite simply. When very little data comes from samples of lifetime survivors alone, most of the data we have on the experience of aging with HIV comes from samples that include individuals who are diagnosed later in life and are currently aging. And then we have even fewer samples of women who clearly have some unique biopsychosocial needs that warrant independent study. So I guess before I move into what I'm about to say, I want to acknowledge that reality that we really don't have the data that we need to have. And at the moment, we'll extrapolate from the data that we do have to think about this a little bit. In an qualitative study done a number of years ago by myself and some colleagues, we asked women how they felt about aging with HIV. And we heard narratives of a lot of stigma and social isolation, uncertainty about the future, worry about managing several chronic illnesses, this inability to understand where a symptom was coming from, if it meant worsening HIV disease, if it was a sign that they had a cancer that someone couldn't detect, and that that, the burden of stress that created. But we also heard on the other side of the coin narratives of strength and resilience. And that's another piece I want to make. We'll talk a lot about, well, how do we help these individuals manage stress and build their resilience? I want to say these people are resilient, period, full stop. And we can talk about ways to kind of help manage the stress of systems that require them to be resilient in the first place. But we heard about the importance of letting go of relationships that no longer served, maintaining relationships that were healthy, making meaning out of aging and aging with this illness and the entire journey of uncertainty that they've carried for their lives, and success and confidence that comes with time around being able to advocate for themselves and being able to take care of their health. Next slide. So again, what do dandelions want and need from behavioral science? We actually have to ask. We don't really know. Based on the data that we do have, next slide. There have been a number of reviews and individual studies about ways to promote healthy aging among persons living with HIV. And a lot of this is kind of what we might expect and is familiar. Again, we need to address mental health, longstanding trauma that perhaps hasn't been treated, ways to build positive social support, cope with systems that create stress, including stigma and discrimination, facilitating access to care and good, effective care that provides those elements that we talked about before. And thinking about health-related behavior change, what health behaviors are going to be the most important and impactful to promoting overall health and wellness. Next slide, please.
All right, so how do we address the substantial unknowns and improve care for lifetime survivors, right? That is the question. We're finally getting some data. We are getting some information we can extrapolate from other studies that are relevant to us. But how do we address this, right? So a major component that comes up within our community is needing to remedy the dissemination of the information we do have. Many of us, like I mentioned, many of us are deeply involved in studies and enrolled in whatever we can, but still somehow can't access the outcomes of even the studies we were enrolled in. We should have gotten them, right? There's the protocols and everything, but being able to access that is challenging. So how do we create a system that includes us, that hears our voices and keeps us present and heard, finding ways to disseminate that more? And then if we want more comprehensive data, we need to design the initial research through a prism that is unique to lifetime survivors until we realize that this cohort is without confines in traditional senses. We will not get the numbers and we will not get the information that we need for our healthcare. Next slide.
I know we're coming close to time, so by way of recommendations, I'll be brief here, but I've tried to categorize them around 3 domains. So assess or explore, acknowledge, and then offer. So we need to assess for structural barriers, mental health needs, and these are wide-ranging from trauma, depression, substance use, anxiety, assess social connectedness, experiences with stigma, sexual satisfaction. So there was another webinar about this, so I didn't spend too much time talking about it, but assess for sexual satisfaction and concerns and barriers that get in the way of having a fulfilling sexual experience, how well an individual is adhering to their medical recommendations, and what is getting in the way if their adherence is not where they want it to be, and again, connection to healthcare. And from this place of assessing and offering, we do need to acknowledge some fundamental truths. So there are, as we've mentioned, structural factors that require so much work in the first place. And we're often designing and talking about these individual level interventions because that's what, is funded. And, many of us, that's kind of what we focus on. But truly, there are structural factors at play that require so much work from the individual in the first place. And we need to acknowledge that. lifetime survivors are resilient, and anything we offer may not be in the spirit of kind of building additional resilience per se, but helping people navigate and cope with these factors that we've talked about today. And then in terms of our offering, we can offer evidence-based interventions that are grounded in trauma-informed care. We can offer evidence-based strategies to target physiological arousal, help people identify values and make meaning and build those social connections. And we can do our best to problem solve barriers to wellness within the context in which an individual finds themselves, and do our best to be creative and think outside of the box. Next slide.
I won't spend too much time on this again because I want to make sure we have time for Q&As. But as Christina mentioned, really ensuring that we remove structural barriers to well-being, because we know that those well-being factors, aka the boring stuff, getting adequate sleep, ensuring a healthy diet and an active lifestyle, sounds easy, right? And they're a little bit like a poly pill, in the sense that they can really target a lot of the complications and comorbidities that we talked about, cardiometabolic and neurocognitive, but they're often really the hardest to ensure that lifetime survivors can achieve. Next slide. I'm gonna skip this slide. Keep going for the sake of time. And I just want to talk about some new pharmaceutical interventions for quote unquote geroprotection. So we're all aging, and there is a science of aging called geroscience, but we also can all age well. And there's we can all try to age well. And there's different pharmaceutical interventions. So I talked about the non-pharmaceutical interventions, such as sleep, diet, and ensuring that, as Christina mentioned, we remove or try to remove structural barriers that can inhibit those. But we have new pharmaceutical interventions that can be used for targeting not only multiple comorbidities, but also the mechanisms such as immune dysfunction, mitochondrial dysfunction, that can inherently be the cause or causal factors for a multitude of aging complications that are listed here. Next slide.
Of course, as soon as I go on, dogs are barking. So just very, very quickly, to me, it's really where do we go from here? And it doesn't just simply mean of identifying who's impaired, but it's understanding who's at risk, why they're at risk, and what interventions are most helpful. But the one thing that's not done into routine clinic care, and I know everybody is extremely busy, but cognition isn't a piece of it. And that's been significantly lacking. I know we've been working with iPads to try to get, cognitive assessments into routine clinic care, but it's a very, very tough thing to do. And I know it's in a really important area and something I figured we'd end up talking about in the discussion anyway. So thanks.
Thank you all so very, very much. Sure everyone can take a collective breath and just realize the breadth of information that we've covered here, which really is the tip of the iceberg. We predominantly stuck to cardiometabolic and neurologic issues today, but we really would like to hear from you in the survey, if you get an opportunity, some of the other co-occurring conditions that lifetime survivors face that we can explore further to try to get some answers to and to try to interrogate and delve into. So I want to put that out there, not just as an incentive to do the survey, but also as an incentive for us to continue to explore what the life course and the lifetime of living with HIV looks like for folks that acquired very early in life.